Hello dear students, today we are going to learn about bacterial tracheitis or bacterial croup, or it is also known as membranous laryngotracheobronchitis. Bacterial tracheitis is a potentially life-threatening suppurative infection of tracheal mucosa, and it results in the formation of a thick mucopurulent exudate or pseudomembrane formation, which leads to variable airway obstruction. It usually develops after the viral croup. Common age group is around 3 to 8 years, more common in male as compared to females, and seasonal variation shows more common incidence around late winter. Most common causative organism is Staphylococcus aureus. Other causes include Streptococcus pneumoniae, Streptococcus pyogenes, Moraxella, H. influenzae B, Pseudomonas aeruginosa in immunocompromised or patients on ventilator. Predisposing factors include history of viral croup, recent endotracheal intubation, and immunodeficiency, and patients with cystic fibrosis, history of trauma, or tracheostomy. Pathophysiology involves initial viral infection damages the mucosa of trachea, impair the ciliary clearance, which enhances the bacterial colonization, and this bacterial colonization followed by the bacterial invasion into the tracheal mucosa causes the mucosal edema, ulceration, necrosis, and pseudomembrane formation. It results in the narrowing and dynamic obstruction of the airway, predominantly in the subglottic area. Airflow obstruction may progress rapidly and it may cause acute respiratory distress or arrest. Clinical features include the history of prodrome, 2 to 5 days of viral croup-like symptoms like mild fever, cough, hoarseness of voice, followed by acute phase with high-grade fever, toxic appearance, stridor, which can be heard both inspiration and expiration, hoarseness of voice, barking cough. But unlike croup, the voice may be weak or absent. Respiratory distress is can be seen as tachypnea, chest retractions, nasal flaring, and cyanosis. There is copious thick purulent secretion can be seen from the uh, trachea, which may lead to the sudden airway obstruction. Unlike epiglottitis, there is no history of drooling, and patient can lie flat on the couch or bed, and there is no need of tripod posture. Investigations. First is airway evaluation. It is the first priority to evaluate the airway for the need of intubation. Do not examine throat in the ward or in the OPD. Always examine the throat in the operating room or ICU settings where we can use intubation if required or tracheostomy if required. Direct laryngoscopy or bronchoscopy can be used to visualize the thick adherent purulent pseudomembranes which coating the trachea, and tracheal cultures and gram stain can be taken from the that part. Lab investigation like CBC shows the neutrophilic leukocytosis. Inflammatory markers like CRP are raised. Bacterial infection markers like procalcitonin is also elevated. Blood cultures are positive in 10 to 20% of cases. Now coming to the imaging. Neck and chest X-ray can show the irregular tracheal narrowing due to the pseudomembrane formation, which is against the smooth narrowing in viral group, and smooth narrowing is seen as a steeple sign in viral group, and here the narrowing is irregular due to the irregular pseudomembrane formation in the trachea, and it appears as a cobblestone or ragged tracheal air column. Sometimes the chest X-ray can show air fluid levels or infiltrates from the aspiration into the lungs. CT neck and chest is rarely needed, and if done, it can show diffuse tracheal wall thickening. Management. The first and highest priority is airway management because early recognition and airway protection is the most important um, management strategy in the uh, setting of bacterial tracheitis, because it can lead to the airway obstruction if not managed early. And management include the endotracheal intubation, and always avoid blind intubation. And the intubation or throat examination should be done only in ICU setting or operating room setting. Rigid bronchoscopy should be preferred over for the airway clearance of secretion and culture collection. ET tube should be of a smaller size because there is tracheal edema, due to which a large size tracheal tube cannot be used. Tracheostomy is rarely indicated, and it is only indicated in cases of failed intubation or recurrent obstruction. Continuous airway toileting or humidified oxygen is essential. Now, the second most important management step is the use of antimicrobial therapy. Start empiric IV coverage for Staphylococcus aureus, including MRSA or Streptococcus or H. influenzae. Empiric regimen include ceftriaxone or cefotaxime plus vancomycin or ampicillin sulbactam if there is low MRSA risk, or piptaz along with the vancomycin in severe cases. Duration of IV antibiotics should be of 10 to 14 days, then switch to the oral antibiotics when afebrile and airway is stable. Supportive care include the use of humidified oxygen, helium oxygen mixture if required, IV fluids, antipyretics. Avoid nebulized epinephrine and steroids because these are ineffective and ineffective unlike the viral group. Chest physiotherapy and suctioning to the chest physiotherapy and suctioning should be done to maintain the airway patency. Now, complications of bacterial tracheitis include acute airway obstruction, tracheal stenosis, pneumonia, lung abscess, and empyema, and in severe cases, there may be sepsis with septic shock. Prognosis is good if early airway management and antibiotic treatment is started with a mortality rate of less than 3 to 5%. However, delay in the management of airway and start of antibiotics may lead to the fatal outcomes, and patients recover completely without any long-term sequelae. Now, the differential diagnosis uh, include the viral croup and epiglottitis. In viral croup, patient do not look toxic, or only mild toxicity can be seen in severe cases. In epiglottitis, the look of child is very toxic. He looks or she looks um, in severe infection, and toxicity is also more in bacterial tracheitis. Drooling of saliva is not seen in either viral croup or bacterial tracheitis, because there is no problem in swallowing the foods. And in epiglottitis, because there is inflammation of epiglottis, it leads to difficulty in swallowing even the fluids. So it leads to drooling of saliva and muffled or hot potato voice. The change in voice in viral croup and bacterial tracheitis is like hoarseness of voice. Sometimes if phonicity, that is he or she, the child is not able to speak, uh, is seen in bacterial tracheitis. Radiology, on X-ray of neck, we can see the stipple sign in the viral group, thumb sign in epiglottitis, and irregular trachea with cobblestone appearance in bacterial tracheitis. Response to nebulized adrenaline is good in viral group. However, epiglottitis and bacterial tracheitis do not show any response to nebulized adrenaline. The fever, incidence of fever and intensity of fever is more common, more in epiglottitis and bacterial tracheitis. So that is all for today. Thank you.